All right, I am going to turn you guys over to Liz Bowers, who is the outreach coordinator for the Evans-Haynes Burn Center, and she's going to go into part deux of our pre-hospital burn care. Liz, they are all yours.
Thank you, Greg. I'm going to share my screen.
Okay.
And entire screen share. Sorry, I don't need to talk you guys through it. Where am I going? I'm going down here. Okay. I need to move you now.
Yep. We see your slides there.
Okay. All right. Okay. Good evening, everybody. Thank you so much for having me back. For those of you who were not part of the first one, we started off with a discussion about burn wounds. We looked at pictures of wounds. We staged them for second, third, and fourth degree. We talked about burn shock, and I think that might have been almost as far as we got. So I had to zoom through total body surface area, and I'd like to start off with that because that is a very critical foundational concept in burn care. So, total body surface area, or TBSA, for the uninitiated, is the percentage of your body that has a cutaneous thermal injury from any mechanism of injury. Um, that's a very important number that we come up with. That is a calculation we do. And that number, A, determines who's going to a burn center in the first place. For example, the American Burn Association's guidelines for burn center referrals state that anybody with a TBSA of 10% or greater partial thickness burns or second degree burns needs to go to a burn center. That number also drives our goal-directed fluid resuscitation. We're going to take that number and put it into a calculation, which will help us do a dynamic resuscitation over time. So that is definitely an important number for us, and we'll talk about that a little bit more moving forward. So here's just the bare bones basics. Especially for field use, the Burn Center and the American Burn Association recommend using the rule of nines or the Palmer method. And I'll start with the Palmer method. The Palmer method, I want to be very clear about. It is the patient's hand. The patient's hand and the full palmar surface, meaning the palm and the fingers, that is approximately 1% of their total body surface area. This is really handy when we're talking about scattered burns, small burns. It's also really handy when you have somebody who is so burned that there's only a few spots of unburned skin, and it's easier to count what's not burned versus burned. I find that that is what I use Palmer method a lot for, actually. It's accurate until you get to about 10% TBSA, and after that, it becomes a little inaccurate. So we would recommend using something like the rule of nines. And you can see this anatomical chart here, the anatomical location of an individual, and their body parts are divided up into multiples of 9. And we're going to practice here in just a second. So get your pencils and your calculators ready. Just so you know, we do not use the rule of nines at the burn center. We use the London Browder chart. You can see that this breaks the body down into more finite areas so we can get a little bit more of an accurate calculation. Due to things that we talked about last time, difficulties in the field in estimation, the fact that it's the middle of the night, the fact that the person is covered in soot, the fact that you haven't debrided them so you don't know what's actually under that slough, all of those things kind of make the London Browder impractical for field use. So stick to the rule of nines, but I like to show you that this exists. Okay. So you can see the chart next to this guy. Second and third degree burns are dark, and the asterisks, those are first degree burns. So in the chat box, when you finish your calculation, tell me what this person's TBSA is. Oops, sorry, I just realized I'm covering up. Yikes, sorry. Sorry. Any guesses out there? Greg, did anybody enter anything?
Yeah, let's see. We've got 27, 37, 32, 33.5, 28, 36, 37, 27, 28, 43, 35, 52, um, 18, 30, 27. So all close to around 30, couple high.
Yeah, look, just a couple high. So first of all, I understand that I'm the one that drew this picture, so I get to say what it is. So I understand that, but I am trying to keep this as realistic as possible. So what I have on this one is 29.5, and I will tell you how I got there. 4.5 for the head, 1 for the right extremity with this palmar surface of that hand. And then you have the anterior and posterior surface of the left arm. So that left upper extremity is 9. And then you have the torso. And this is where it gets a little tricky because you can see that the torso on the model over here is the torso includes those inguinal lines, the groin, and our guy is missing that. So I took an imaginary one of his hands and I said 1, 2, 3. I took 18 minus 3 and I said that this was 15%. And that's how I got to 29.5. I think that recognizing the anterior and the posterior surfaces of an extremity is important. I think recognizing a partial burn in something that has been designated on the rule of nines, like an 18, if it's partially burned, make sure you're subtracting what's not burned. And then the last thing I think that the really high ones may have done is included the first degree burns into that calculation. If you remember from last time, we do not include first degree burns in TBSA. Very common mistake from EMTs to physicians. I see it all the time, but just to take that out of your calculation. All right. This one's a little easier.
While people are calculating, there was a question in the chat. Is it better to be a little high or a little low?
Uh, I don't even, what's the answer to that? Well, so here's the problem, and this is going to be so unsatisfactory to whoever just asked that question, is we're not looking for this like super targeted exact answer because of all those variables that we were talking about earlier, the soot, the debridement, the time of day, and all that other kind of thing. What we're looking at is a range of error. So if you are a little below or you are a little high, as long as you're close enough, we're going to say that's fine. But if you're so off that it's changing the clinical course of this patient's treatment and they didn't need it, then that becomes a problem. Or if you didn't resuscitate a big burn and it really needed the resuscitation, that's where the problem is. Okay, what did we get?
Let's see. I saw a lot of 11s. Somebody said 13 to 15. There's a 20, a 15, another 20, 13, 11, more 20s. So right around 11, 12, 15, and 20, it looks like.
Okay,
I'm looking
so
as I
I
go
would
through.
say I have, first of all, I have created controversy by coloring in the heels of this picture. It has caused much drama in a lot of the talks I've given. I will tell you, all because of these little heels, it is 11 to 13 would be correct. And I have 4.5 for the right lower extremity, 4.5 for the left lower extremity, 1 and 1. However, as people have correctly pointed out, I've done the soles of the feet there, which would be 1 each, hence the 13. So about 11 to 13. Now, what we're moving into is pictures of real burns. And you're going to see how these have been very conveniently colored in to include half of a body part, right? We're going to see the scattered nature of these. So here come some pictures of real burns. So this is a 28-year-old female who was in an apartment fire in the middle of the night and went back in to attempt to rescue her children. And there was a fatality in this fire. She was ambulatory on scene, coded at the outside hospital. They got ROSC after good ACLS and transferred her to us. And she ultimately did amazingly well considering the severity of her burns. Anyways, I just like to add that context. So, in this setting, it's kind of hard, but we can use the chat for this as well. Looking at her face, it's hard to see because we're not seeing the left side, but I can say it's essentially equally as burned as the right side of her face. So that would be, I gave it 4 because she does have a spot on her nose and her forehead and along her cheek here that's not there. And there's a little bit on that other side that you can't see. So I said 4 instead of 4.5. Her extremities, what do you guys think those are? Her upper extremities. I can tell you that the left one looks like the right one, except it's not as pale. Greg, what are the answers coming in at?
Let's see. Yeah, let's see. We got 4.5 times 2, 7.5. Somebody says total of 11. Got some 9s.
Yeah, so
Both of them equal 18. So
yeah, and it's not fair because I don't have a picture of her arm being elevated for you to confirm. I guess it would be more the anterior surface, her hands rotated down. But I can tell you that this is a circumferential full length of her arm, full thickness injury, and the left side is full thickness and deep partial thickness, circumferential full length of her arm. So that would be 9 and 9. So we have a total of 18 there. And her back, what do you guys think this back is? If a normal torso is 18,
18, 9, 10, 15, 12, 13.
okay, so in the correct range there, and I'll tell you the way I did it. So I'm saying like this right here is about like halfway down her back, and so half of that would be 9, and then if we add some of this stuff into some of the gaps here, it could be 9 to 10 is what I would say right there. Okay, and then this is the complicated part, is her legs.
While they're looking at that, there was a question about the upper extremity, the blanching on the upper extremity. Can you explain
Yes,
on that a little bit? Yeah.
yeah, the right upper extremity.
Yes.
Oh, I guess I shouldn't go. Wait, well, let me just point to it real quick. This guy right here, if you guys notice how absolutely pale that is right there. And then you can see the left arm is much more red and almost like hemorrhagic looking. Um, that is due to the fact that that right upper extremity is a full thickness injury. Full thickness injuries are pale, they're waxy, they're hairless. You will see contracted hands, like you can see on her hand is contracted. There'll be um, coagulated blood vessels underneath the skin, and it is usually insensate or has a dulled pain response when it's a full thickness injury. And you're right, it does not blanch. Blanching is a good sign, like cap refill, but a full thickness injury will not blanch. Okay, What are we thinking about these legs? How about the left lower extremity? This took me a minute.
And are those
So
circumferential also?
these are circumferential, although there's a patch behind here that is not burned, that's on this other side, the posterior side of that. Yeah, I basically took, I know that we know that the whole leg is 18, 9, and 9. And so I did the Palmer method to figure out how much of that isn't burned. So I said 1, 2, 3, and then 4 for this two pieces that are connected in the back. Um, yeah. So I ended up giving it 14 in total. The right leg, on the other hand, I used the Palmer method again to calculate this, but I'm using the actual burn this time. So I'm saying 1, 2, 3, 4, 5 is what I'm saying. Now, when you are approaching this in the field, do not try to do this in your head. What I suggest is you get a piece of tape on your leg, or something like that, a piece of paper, and write down head, torso, right upper extremity, left upper extremity, right lower extremity, left lower extremity, and back. And I would go through every single one and do what we just did and apply a singular number to that, and then add it up at the end. So we have 4 for the head, 9 for the right upper extremity, left upper is 9, back is 10, right lower is 5, and left lower is 14 for a total of 51. So that's a big, um, what's the concern with the circumferential injuries, especially to that right upper extremity, but to both upper extremities? What are we concerned about mainly when it comes to her extremities? Somebody can unmute yourself and say it, or
Compartment syndrome?
yeah, compartment syndrome. And do you know what procedure she would need to prevent compartment syndrome?
Not the name, but it's the lateral cuts along expanding lines.
Right. Yeah. So that tissue that is the dead skin, escharotomy. Yeah, escharotomy. Yeah, because the tissue that is dead is called eschar, and we cut right through that eschar to release the pressure of that compartment to allow it to swell safely. Um, and that's how we do that. Okay, so here's another one. Now, this is going to be a little awkward, odd, the first picture. Oh, just kidding. Going backwards. I'll explain. Our next patient is a high voltage electrical injury. This was a tree trimmer that hit a high voltage power line while they were working. So that's over 100,000 volts. And they were lowered down in the bucket truck. And he was brought to an outside hospital where their orthopedics team determined that he was showing signs of compartment syndrome in that left upper extremity. So they took him to the OR and performed fasciotomies, not just escharotomy. So this goes all the way down to the muscle fascia. But when we're looking at his TBSA, when you look at that wrist portion, I know this is obviously super distracting, but what we're counting is just the actual burn part. So, what would you say that this burn here is as far as TBSA? Any guesses, Greg?
Um, 1, 2, 3, and 5 is what I'm seeing. There's
Okay,
a
yeah. So what
3.5.
what I chose to do is I just imaginarily took the patient's hand and wrapped it around the wrist and said, that's one. And then you see that he's got some damage, like burn to his actual palm as well. And maybe that's a little bit more than a thumb on the other side. So I said that this was 1.5. Now let's look at his lower extremities. This is his right. We have a better picture of his right coming up because it sustained a lot more damage. This is his left. And his left lower extremity, how many do we think this is?
2, 3, and 4 is what I'm seeing.
Yeah, I put 4 down here, but I'm not going to tell the people who said 3. I think it's more than 2. But if there's a little variability, that's fine. Okay, so um, in electrical injuries, like in gunshot wounds, we do not say entry wound or exit wound. We say contact points, especially in AC power. It's an alternating current, meaning it's going back and forth. So every contact point is, in fact, an entry and exit point for that. So you can't just say it entered there because it's actually doing both. But his contact points were to the left upper extremity that you saw at the fasciotomy, and then here is the damage his right lower extremity took. Um, really good example of a 4th degree burn on his pinky and probably 4th toe right here. You can clearly see the white outline of a full thickness injury, and you can actually see the coagulated blood vessels that we were talking about also as signs of a full thickness injury. Additionally, over here, you can see that that injury goes all the way up and is again full thickness here and spares the top of his shin, his knee. We have some 2nd degree burn on the lateral and posterior axis of the right leg there, and then maybe another clear spot there. So if this leg is 18 in total, how much of this is burned? Let's get some guesses.
9, 10, 14, 15. Seeing a lot of 14s and 15s.
Okay, I put 13. And really all I did was I did Palmer method. So I said 1, 2, 3, 4, and then there is a spot behind here that's unaffected. So I said 5, 18 minus 5. So that's how I got to my 13. All right. Let's talk about burn shock. So this was another thing I glanced over really quickly, but I just wanted to remind you guys that burn shock is more than just the localized burn. We talk about burns, we think about the pain, some scarring, maybe the loss of the function of the skin, but really what we're talking about is what big burns do systemically to the body. And big burns are defined as 20% TBSA or greater. These are the patients that we know are potentially going to go into burn shock. It is a cell-mediated response to massive tissue injury. So when the cells get injured, cytokines get released into the blood, and those cytokines, those chemical messengers, are vasoactive. They decrease the squeeze of the myocardium. They increase the peripheral vascular resistance, which is terrible for end organ output. And there is a progressive capillary leak. So you're really looking at a mixed shock state. It's distributive and hypovolemic, and it can be really complicated. Burn shock is progressive, and one of the biggest pitfalls we see out there is kind of the old medicine thought process still hanging around is we give burn patients all the fluid in the world, go, 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 fluid, fluid, fluid. And people tend to bolus them and things like that. And I'm here to tell you that even big, big burns take a really long time to kill somebody. I will tell you a story to prove this point. I was working at MedStar in DC in the burn ICU, and there was a man who, in a political statement, did an act of self-effication or what is it? Self-immolated himself. Sorry. Sorry, it's not funny. He emulated himself. And he came into our unit, this was 2 o'clock in the afternoon, and he had 94% third and fourth degree burns. The only things that weren't spared were his feet because he was wearing boots and somehow his face. He was not intubated and he was talking, and it was the trippiest thing to see somebody that horrifically burned. And he was saying, yes, ma'am, no, ma'am, thank you, ma'am, very calmly. And the whole reason he wasn't intubated was because he was refusing care. Now, the first question everybody asks is, does that guy have capacity to refuse care? Hence why all 3 burn attendings and all 3 hospital ethicists were at the bedside having a robust discussion about whether or not he had the ability to refuse. They brought his mom in, and she said he can refuse. And based on how extensive those burn wounds and what the kind of compliance he would need to actually heal and have a productive life, everybody agreed that he did not have to be resuscitated. So we bandaged his wounds. We did not give him an ounce of fluid. We gave him a lot of Dilaudid, and we put him in a quiet room with his mother to pass peacefully. Again, this happened at 2 p.m., and he didn't die until 10:30 that night. That is a long time to be sitting there with almost entirely third and fourth degree burns in your body. Now, let's say he had a grade 4 liver lac. How long would he live? Minutes? Minutes if you're lucky, right? Trauma trumps burn, always. And also, burns, even big burns, do not cause immediate hemodynamic instability. So if you pull somebody out of a structure fire and they are really shocky, like in circulatory collapse, or they're super altered, it's not the cutaneous burns that are causing it, it's something else. So you have to ask yourself, what else is going on? Did they inhale cyanide gas in this structure fire? Did they jump out of a second-story window to extricate themselves and now they have a pelvic fracture? All of these things are potential underlying causes, but it's not going to be the burn. So, resuscitation is kind of like a Goldilocks rule. We want just enough fluid to perfuse the end organs, but not enough fluid that you're going to over-resuscitate them. And between under-resuscitation and over-resuscitation, we primarily over-resuscitate people. And that's usually through the use of boluses and giving lots of fluid, and sometimes overestimating the TBSA because they've incorrectly added in the first degree burns. That's another way commonly that we see over-resuscitation. Now, with under-resuscitation, if somebody's hypovolemic and we don't give them fluid, we know what happens, right? The first thing that takes a hit is their kidneys, and then they go into multi-organ dysfunction syndrome, and then they die. Over-resuscitation, though, increases the capillary leak of the burn shock, which increases compartment pressures. It can cause pulmonary edema, cerebral edema, and the people most at risk for over-resuscitation are the people who are always at risk for over-resuscitation, and that's children, geriatrics, renal failure patients, and heart patients. So what do you need to start classic burn resuscitation? You need the patient's weight in kilograms. You need a TBSA. You need a Foley catheter. You need venous access. You're managing their airway. You're deciding if you're going to land a helicopter. You're going to drive them. The wife is screaming at you. You have a lot of things going on. And we've traditionally been like, and here's a long division problem. Can you figure it out? That's not entirely fair. It's not effective. And you also can't put Foley catheters in to monitor the urine output. So why National Registry is still testing to this, don't ask me. I'm just saying it's impractical. So the American Burn Association has come up with this. This is the initial fluid rate. These are for people who are burned 20% or greater. But the American Burn Association says you don't even have to take the time to calculate that formula. You can look at somebody, and if you go, dang, that person's burned, then you can start the fluid. And it's by age only. So children 5 years old or younger get 125 milliliters an hour. Children 6 to 12 get 250, and 13 years and older, they get the 500 milliliters an hour. And they can stay on this all the way until they get to the burn center. Okay,
Hey, Liz,
so here's the, yeah,
there was a question. Isn't there a growing interest in the value of plasma for fluid resuscitation versus any type of IV fluids?
there is. FFP, when I was at MedStar, they started a trial of FFP, and actually in our last PIPS meeting, which is Performance Improvement Patient Safety meeting, um, we are going to start writing protocols and introducing FFP in our fluid resuscitation. So yes, that is coming down the line. Okay, airway and inhalation injury. So there are three types of inhalation injuries. There are upper airway injuries, so that's like above the cords, below the cords or lower airway burns, and then systemic poisons. So upper airway burns, I think this is the one we always kind of think of because, especially if you're an intubator, it's kind of what you think of. Um, and you have this whole structure here. It is designed to warm and humidify and filter the air that you're intaking. And to do that, it needs to be really, really vascular. And what happens when really vascular material has an insult? It swells. So all of that tissue is getting hit with superheated gases. So when and the firefighters out there can correct me, but I've been told that when you're at like standing height inside of a burning building, the air you're breathing is probably like 400 to 500 degrees. And then the ceiling is like 1,000 degrees. And the really, really hot ones will actually physically push you down to the ground. You're not able to stand up, but you're inhaling those super hot gases and they're coming into contact with that supravascular tissue and it starts swelling and it starts obstructing your trachea. The good news about this is that it's a very simple fix. And I understand I get to say it's very simple because I'm not the one sitting there trying to do it as we speak, because it's challenging. This is a challenging airway. But in theory, if we can place the endotracheal tube, we let the tissues swell, the tissues come down, we actually start listening for a cuff leak. And a cuff leak is a good sign because it means the swelling has gone down. We'll do a few more tests and then we pull that tube, sometimes within 12 hours of their admission, sometimes 24 hours, and then they're gone a day later. They do really, really well. Um, Airway management, obviously, if you're not ALS, you're not going to consider intubation, but maybe your protocols allow a secondary device, which we'll talk about in a second. So the indications for intubation and suspected airway injury, especially upper airway, medicine is a pendulum. And the things that we did back in the day are coming back around again. That's exactly what's happened with intubating burn patients. We used to, if somebody singed their mustache or had a singed nose hair, we were RSIing them and intubating them. But it turns out we were intubating a lot of people that didn't need it, and it's definitely not a procedure without risk. So who are the people that need to be intubated? So anybody with stridor, obviously stridor is a impending sign that you're going to have an obstructive problem. Anybody who's hoarse or has a scratchy throat or a voice, asking them about it. Does your voice sound normal? Any soot in airway, but when I say soot, I mean like if they look like they ate a charcoal briquette, that person might need to be intubated. Deep and extensive facial burns are a high indication that somebody would need to be intubated. Carbonaceous sputum, which is black, frothy nastiness that you can suction out of somebody's airway. We in the ED will do a direct laryngoscopy. We'll just put a camera down your nose and directly visualize the larynx to see if there's soot and swelling. And then for large volume resuscitation would fall under expected clinical course for intubation. For those people, even who maybe don't have an airway issue, we're going to be giving them so much fluid over time that we're going to cause them to swell, potentially including their airway. So we intubate them up front, give them the volume, and then we can, give them Lasix and stuff later. So for intubation and RSI considerations, the burn patient is the time for the most experienced provider to be performing the intubation. It's not the time for the intern or the person who really wants to get one under their belt. For us, anesthesiology or pediatric anesthesiology is the people intubating, that patient. There's also a kind of an old not a wives' tale, but like something in the past where people would say you need to intubate a burn patient with a smaller tube, like downsize a tube right away. And I'm going to say, try with a normally sized tube first, because I'm going to explain to you a lower airway burn here in a minute. We need to be sucking out a lot of really nasty slough and junk. So we're going to need a big tube to do that. And then we're also going to want to do bronchoscopies, is putting a camera down into somebody's lungs, and we can actually suck out certain things that way. So we need a large tube to do that. Always have your secondary airway ready. Just know that supraglottic airways work on path of least resistance. And by definition, in an upper airway burn, you have your airway have a lot of resistance. So the path of least resistance may be the esophagus or out your mouth. So just be aware. I'm not saying you can't use it. It might be more of a bridge to a more definitive airway. But that's the trouble with a supraglottic in these situations. Avoiding succinylcholine, burn patients, because they have massive tissue injury, have hyperkalemia. When cells lyse, they break apart and spill their intracellular components into the blood, which includes potassium, and succinylcholine also raises potassium levels. So you risk driving them into a deadly hyperkalemia. And then securing the tube. Now, you guys all have Thomas tube tamers or some commercial device, which is really nice, simple to use, holds the tube great. At the hospital, we are not allowed to use commercial devices because they have bite blocks in them and hard plastic. And these people are going to be intubated for a very long time, potentially. And they're also going to swell. And the tissue, as that grows and swells and pushes up against those hard structures, will actually split lips in half and cause devastating injuries. I've seen tongues cut in half, all sorts of bad pressure injuries due to devices. So we have to use stretch netting and tape, and which can be really hard if you have facial burns. We're always trialing new tube tamers for facial burns. Okay, lower airway burns. Now, upper airway burns, that was a simple fix, and these guys are extubated in 12 or 24 hours. Lower airway burns, not so much. This is big bad. Where upper airway burns was heat coming into contact with the upper structures, lower airway burns is due to the nasty toxic chemicals that you're inhaling in that thick black smoke. It's coming into contact with the epithelial lining of the lungs, and it causes tissue sloughing. It causes increased mucus production. And you have decreased ciliary action. So you have all this mucus, all this slough, and the little hairs that normally move that debris out of your airway can't do that. It decreases surfactant production. So you have de-recruitment, decreased oxygenation. Eventually, it'll wind up in pulmonary edema. You'll probably go into ARDS. And ultimately, all of this leads to a profound ventilation perfusion mismatch. The lungs are getting perfused, but there is too much physical debris in the way to participate in oxygen exchange. The burned lung tissue also counts for total body surface area, but we can't account for it. So what we may find is we have patients with increasing resuscitation requirements who are getting sicker and sicker and sicker. And we're like, why are they so sick? And then we do a bronchoscopy and we figure out, oh, it's because they have a grade 3 inhalation injury. So they may have more resuscitation requirements, and lower airway burns are so deadly, in fact, that they can raise your mortality up to 50%. There's a score we call a BAUX score, BAUX. It is the mortality score for burn patients, and we take the patient's age, time, or plus their TBSA, and we add on a full 17% the presence of an inhalation injury. Okay, systemic poisons. We have inhaled byproducts of incomplete combustion, and it's toxic inhalation. And our two most common offenders are carbon monoxide and cyanide. Carbon monoxide is a colorless, odorless, non-noxious gas that is in all products of combustion. So every single fire is going to have carbon monoxide. It's our most common thing that we see. It has 200 times affinity to hemoglobin of that of oxygen. So it will physically competitively displace oxygen off of that hemoglobin molecule. And the classic symptoms are headache is the big one. Throbbing, intensive, like gets worse and worse and worse as you go on until you have a seizure or you go into a coma and you die. Seizure, coma, death. Every neurological compromise, right? That's how it ends. Seizure, coma, death. Very importantly, and I know this is review for some, but we see it a lot, so I bring this up. You cannot use SpO2 on patients who have been in an enclosed space in a structure fire like this, because it will not tell you if they're oxygenating. What an SpO2 is reading is the saturation of the hemoglobin molecule, not what it's saturated with. So you could be 100% saturated with carbon monoxide and it's going to read 100%. So throw that thing out the window. If you have a rainbow cable, great. Rainbow cables are good enough to rule in, but not good enough to rule out carbon monoxide. So we always go by index of suspicion. Enclosed space, fire, carbon monoxide. So we draw a lab, it's called a carboxyhemoglobin. We draw this off of an ABG, and these are generally the levels. Now, people usually are 0 for most people, but if you're a smoker, you might live in the 5 to 7 range, or if you work at a toll booth where you're around a lot of exhaust or something like that. But if anybody's hitting 10, they've had a significant exposure. You can see talk of the headaches and this slow, or I should say rapid decline. I personally have never seen anybody live above 50, personally. Okay, what's the treatment though? If they have a decreased level of consciousness and can't protect their airway, establish an airway. But the definitive treatment for carbon monoxide poisoning is oxygen, 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 oxygen. You should have anybody suspected of an inhalation injury needs to be on 100% oxygen. Full stop. The heart people, the stroke people have done a really good job teaching us about free radicals and oxygen toxicity and blah, 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 blah. Not in burn. In burn, if they were in an enclosed space with a fire, 100% oxygen. Our protocols at the hospital state to give somebody 6 hours of 100% oxygen. We'll redraw an ABG. If their carboxyhemoglobin is still high, we'll give them another 6 hours. So don't be scared of it. And occasionally I've seen documentation where the crew wrote, oxygen not on patient because SpO2 above 94%. That's not understanding the pathophysiology, right? So I just want to really bring that up. Okay, cyanide. Now this is the products of incomplete combustion of synthetic materials. So like everything in our lives, everything. Plastics, vinyl, foam, upholstery. Car fires are crazy cyanide producers. Living room, couch stuff, all of that stuff, when it burns, it produces cyanide gas. Cyanide gas inhibits the Krebs cycle in the mitochondria, which is the powerhouse of the cell. It switches and it severely reduces ATP production. So you have a reduction in ATP, and your byproduct is lactic acid. So you're going to have a profound lactic acidosis. Now, what's interesting about cyanide is technically there is a lab, but it's a send out lab. And so we have to send it to like Georgia or something. So they'd be dead before we ever got that information back. So we use index of suspicion. If somebody was in an entrapped space with things burning like a car or a house, we treat them with the antidote. Or if they also have a lactic acid acidose, or excuse me, lactic acid of 10 or above, that is also a presumptive positive for cyanide. The antidote here of choice is Cyanokit. I know there's a shortage right now. It is cost prohibitive and only has a 36-month shelf life. So those are reasons why agencies may not carry them, but it is an easy delivery. It comes in a really handy kit with all of the material you would need. It's an easy administration, nothing like sodium thiosulfate. That was a pain in the butt. And the only side effects are temporary hypertension and turning all of your bodily fluids purple. That's the fun one. Here's an example of that. This is urine from somebody who just received a cyano-kit. This lasts for about a week. It gets pink over time and then clears the system. The active ingredient is hydroxycobalamin, which binds to cyanide to create cyanocobalamin, which is excreted harmlessly through your bodily fluids. Okay, I got 12 minutes left. Let's see what I can do here. I want to talk to you about burn recovery and what it starts to look like once they get to the burn center. For big burns specifically, but small burns over important anatomical points like major joints is a lifelong experience. If you remember from the first lecture, we talked about how the dermis here holds all of those dermal appendages, and that's what gave the skin the functionality, like the sebaceous glands that moisturize the skin with sebum, or the sweat glands, which aid in thermoregulation and fluid and electrolyte balance, or your nerves that help you actually interact with and obtain sensory information from the world around you. All of those things, when they go away, life is a much different experience. They tend to have long lengths of stay in the hospital with multiple complications. There can be several multi-drug resistant organism infections on one patient of different kinds and different locations. So that's something we work with infectious diseases with. And burns, because you saw how systemic burns truly are, it affects every single system in the body. So you can have something go wrong in every single system. Amputations are common. In fact, the electrical injury that we saw earlier with the fasciotomy, he lost his left arm and right leg, or I should say below the knee amputation due to those injuries. So amputation is certainly in those 4th degree cases does occur. And then we're going to talk about scarring and contractures and webbing. There's extensive intensive care, and when you are doing a long time intensive care is invasive care. So if you have an orifice, we put something in it. And if you don't have an orifice, we make an orifice and put something in it. That is what intensive care does. Everything from your nose to your toes, you're going to have something on you or in you. And invasive care is not without its own risk. Blood clots, DVTs, PEs, infections, I mean, you name it, it can happen. So those are the realities of being in an ICU. We have really cool technology these days, though, and this is where it gets exciting. We have skin substitutes. Don't work on full thickness injuries, but partial thickness injuries, and they stay on until the skin is healed. So if you can see at the bottom left, this is a wound that's cleaned up really well in the OR, and they've placed down, this is called suprathel. And as the epithelium grows back, the suprathel actually lifts and they trim it away until it's all gone and you have perfectly healthy skin underneath. So that's pretty cool. But the bread and butter of a burn center is grafting. And the ultimate goal, the end point of all grafting, is to have autograft. auto meaning self. The end point is for us to harvest skin from you and make a graft out of it and put it on a burn. Now, this typically has to happen in a staged approach. Staged approach meaning that initially when you're burned, that wound bed is under a heavy insult, and the wound bed is not ready to accept an autograft. You have to have stellar nutrition. You have to have no inflammatory process. You have to have no infection. You have to have blood vessels and things start regrowing in that wound bed to prepare it to accept an autograft. So, what we do before is lay down either animal or xenograft, like in this case, this is tilapia skin, or sometimes they do porcine skin. Now, we don't do tilapia skin at our burn center. We do allograft or homograft, and that is cadaver skin. So we get donated cadaver skin that we use. That actually promotes the revascularization and reepithelialization of the wound bed. And then once that is complete and they're ready to go, we will lay down the autograft. And then I'm going to talk about RECELL and CEA because that stuff is bananas. Okay, autograft. We take a harvest site. I mean, ideally, it would be like a buttock or a thigh or a flank. But we are going to get it wherever we can get it. Our 90%ers, for example, I've seen scalps harvested. I've seen feet harvested. So you get it where you can get it. And then you run it through a mesher. And this mesher here can be 1:1 to 1:6. And what that does is it increases the surface area of that graft. So we are taking less skin and covering more with it. This is a time-lapse picture of autograft being laid down. No, they did not use a staged approach in this. They went straight to auto. But you can see the obvious third-degree injury here. The actual surgical excision of that injury, laid down graft, and beautifully healed. I have some videos for you. This is called tangential excision. So with that one, tangential excision, that's called a Weck blade. And what you do is you slowly shave off layers and layers, and you keep cutting until it bleeds. That's the picture we saw in that time-lapse video. We saw it bleeding. You want it to bleed because if you need for healing and for it to adhere to an autograft, you need vascularization. If you're cutting down to dead tissue and it's not bleeding and you put a graft on it that we've harvested from your skin, you're just going to lose that graft. And we take graft loss very seriously. Here's actually using a dermatome to harvest a skin graft. And what they're talking about now is putting it through that mesher that we were talking about. And they said it's a 2-to-1 mesher. Now they're going to lay down the graft. And I think this video got cut off a little bit, so I apologize for that. Yeah, that kind of, all they did was spread it out a little bit. And the video that I couldn't get to transfer over, you can either suture or staple in grafts. In this particular one, they were stapling in the graft. So you staple the borders. And then, of course, to take those staples out, we'll put them under sedation to take those staples out. We're not going to make them be awake for that. And then lastly, this is a silver impregnated dressing that we place over the grafts. It has pores in it so it can weep. And this is an antimicrobial layer. It's also non-stick. And then what they'll do, why that long piece of gauze is under them, you add an absorbent layer on top because burn wounds and newly harvested wounds weep a lot. There's a lot of insensible fluid losses that occur. Greg, can I do resell in CEA or what's up? We have 2 minutes.
You have 2 minutes, but you know better than I do.
Okay, real quick, because it's too cool not to leave it with you. Okay, so resell is really inexpensive. It's in the operating room. It's the size of a lunchbox, and you take a 1 centimeter square centimeter of the patient's skin while they're in the operating room, and then you take it over to this little box and you kind of separate the skin cells, and then you put it into this little well, and they have an enzymatic solution they add to it and it heats up and gyrates and stuff. And then what they do is they take a syringe with an atomizer on it, essentially an atomizer. It's more of like a spray. And they slurp up that slurry and they spray it back on the patient. It's spray on skin. It's really cool. It can cover for 1 square centimeter, can cover 80 square centimeters. Think about that. We can put it on faces. We can put it between the mesh of an autograft. We can put it on donor sites where we took it. I mean, it's awesome stuff. And then Big Gun, Big Daddy right here. This is cultured epidermal autograft. This is living in the future. And this right here is why 80% burns are walking off our unit. It's also why 80% burns are spending 6 months in the ICU instead of a year in the ICU. This is a special biopsy that we do. For patients who are 60% and above, when they come in, we take a special biopsy and then we send it to a lab in Boston, and it takes a few weeks to get back, but this is the patient's own skin grown in a lab. It's really man-intensive, like man-hour intensive, and there's incredible infection precautions that have to go along with it. They can't have visitors. Anytime you walk in the room, you have to change your scrubs. Like, it's pretty intensive. It's a big, long OR day, but it is literally the reason why big burns are living. And I'm going to leave you there. I have more I want to give you.
Well, they already are calling for part 3, so. Okay. Before anybody goes, please check the chat. I've got some people I can't identify because you don't have your name under your picture, and I can't give you credit if I can't identify you. So please check the chat. I sent some questions to people asking who they were. There's at least one person who's on a Samsung phone that I can't see who you are, and I want to give you credit. Otherwise, I've recorded everybody's attendance here. I will, again, force Liz to come back for part 3. And like I did last time, everybody who came to part 2, if you want to come to part 3, I will email you a day or 2 before I actually open it up to the public, since you guys have already been here through part 2, to give you first shot at part 3. There's a question, Liz, should we be elevating extremity burns? And do you have a preference for IV IO access sites and sizes?
I'm so happy you mentioned that. Like, elevate, 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 elevate. Now, do not use ACE wrap because that would be compressive, and anything that decreases perfusion to those burns will potentially convert it from a lower degree to a higher degree burn. but elevation is key. It is the first thing, especially in circumferential, It's the first thing the doctor's going to ask is, are they elevated? We actually take stretch netting and we hang people's arms straight up from IV poles, and they sleep like that. But we do that all of the time. Anybody in bed has pillows on all four extremities. It is certainly a way you can really make a big impact in the field.
Awesome. Anybody else have a question? Those of you who, if you need to go, you're welcome to log off. I have you recorded here, except for the people who I need to name. But does anybody have any other questions? If you guys want to hang around for questions, you can do that too. But if you need to go, I certainly understand. Feel free to unmute and ask your question, or you can put it in the chat. Either way, I'll hold Liz hostage until all your questions get answered. I see somebody with their hand up. Go ahead. If you want to unmute. You're my Samsung person who's on your phone. You can go ahead and unmute and ask your question. Is it worth nebbing epi via the ETT? I guess for inhalation burns, Liz.
We would go with albuterol. So the cocktail we give them at the hospital is albuterol, mucomist, and heparin. Albuterol for the bronchospasms, mucomist because it dissolves nasty booger clots. And we'll actually go in there with a bronchoscope and target it and like inject nasty solid masses of mucus, and they dissolve, we suck them out. And then we do the heparin because part of the inflammatory cascade is clotting factors, and microemboli will tend to develop in the lungs, also increasing that ventilation perfusion mismatch. So I would do albuterol instead of the epi, and then we'll just continue that at the hospital. And I saw the hyperbaric chamber. So it's sexy, I'll say that. But there's not a lot of definitive research out there that says that it's beneficial or leads to improved outcomes. Oftentimes, when I've talked to providers anyways, often what happens is we will transfer, or not necessarily we, but somebody will transfer out somebody to a center that has carbon monoxide, and they actually don't end up diving them because they've cleared it on the high flow oxygen on the way to the hyperbaric. I think for non-burn wounds, like diabetic wounds and some other things like that, much more reliably effective. Anything else?
I don't think so. I think that's it.
Great. Well, thank you, everybody. This was an absolute pleasure, and I look forward to coming back for, is it trois? Deux, trois?
Yeah, trois. Part trois. All right. Thank you all very much. Have a good evening.
Thank you, Liz. Thank you, Greg.
Yep.
Thank you.